Well, look, thank you all for registering and attending the APRU University of Sydney Crisis Management webinar with a theme titled The Impact of COVID-19 on Non-Communicable Diseases. From where you're all zooming in from across the Pacific region, good morning, good afternoon and good evening. To begin, a little light housekeeping. Please ensure your mic is on mute. And if you have any questions, please hold them to the end by using the Q&A function, and I'll read the questions to the panelists to in turn answer you. Let me first introduce our chair, Professor Joel Negan, who is head of school, Sydney School of Public Health at the University of Sydney. Professor Negan's research interests involve strengthening health systems in countries with lower socioeconomic status. He maintains collaborations in Uganda, Vietnam, Indonesia, Fiji, and maintains a passion for capacity in building the Asia-Pacific region. Dr. Christopher Tremowan, Secretary General, APRU. Dr. Tremowan was elected the APRU's fourth Secretary General, taking up the role in 2011. He specialises in social regulation in the Southeast Asia. His research is recently focused on the internationalisation of higher education. Assistant Professor Hui Lin, School of Public Health and Department of Pharmacy, Faculty of Science at the National University of Singapore. Her research interests include economic evaluation of health technologies and health services and incorporating patient and public preferences in the design of health services and health policy. Professor Tony Kuo, Adjunct Professor, Department of Epidemiology, I beg your pardon, Epidemiology, I'm sorry, UCA, I'm a bit nervous, UCLA Fielding School of Public Health. His professional interests span the whole of medicine and public health. They include undergraduate and graduate medical education, nutrition, physical activity promotion, tobacco control, cardiovascular health promotion, diabetes prevention, patient-centered care, and social programs that affect health. Associate Professor Melody Ding, who is Associate Professor in Public Health, University of Sydney. Associate Professor Ding is an epidemiologist and population behavioural scientist. Her research includes climate action, public health, chronic disease prevention, built environment and health issues in China. Assistant Professor Zhui Liu, beg your pardon, School of Public Health, Peking University. Dr. Liu is an assistant professor of epidemiology and biostatistics at the School of Public Health, Peking University, and application in health. Her research interests include epidemiology of infectious diseases, prevention, control, and management of infectious diseases, maternal and child health, big data research, and application in health. So Professor Negan, I'll leave it to you now.
Great. Thank you very much, Brooke. And thank you very much to everyone who's attending our session today. As is tradition in Australia, before we begin, I'd like to do an acknowledgement of country. I'd like to acknowledge the traditional owners of the lands on which we meet, the First Nations peoples of Australia. In the case of where I'm sitting here today on the University of Sydney campus in Sydney, Australia, it's the traditional lands of the Gadigal people of the Eora Nation. And I pay my respects to their elders, past, present, and emerging, and acknowledge their 60,000 years of continuous culture and learning and knowledge production on the lands on which the University of Sydney is built. As Brooke mentioned, I'm the head of the School of Public Health here at the University of Sydney, which is the oldest school of public health in the Asia-Pacific region, with our founding in 1930. And we've been a very proud member of the Asia-Pacific Rim University's program for a number of years, and we take great pride in our collaborations with our university partners across the Pacific region. As someone who grew up in Canada, I feel like I straddle the Pacific a little bit on both ends, so it's always an honor for me to participate in these sessions. APRU has had these global health webinars over the past few months, and this is, I believe, the fourth one in a series of webinars on global health that particularly reflect the challenges of the COVID epidemic, which is almost exactly 1 year old in terms of when it really started to cause global shutdown and changes to how we address not just global health, but economic systems, travel, and so on. Some of the other sessions have been on the ethics of COVID and other topics, and this one takes us into, I think, a really critical area to remind us of that a lot of the global health and public health conditions and priorities that existed pre-COVID are still priorities, are still challenges in our communities. And so this is about the impact of COVID-19 on non-communicable diseases, whereas a lot of our attention is very much focused on the infections. Right now, this session is going to allow us to return our focus to some of those non-communicable disease challenges. So I'm really looking forward to the session with 4 great speakers from across our APRU family. So looking forward to that. I'll be moderating that over the course of this session. Please do reserve your questions for the end, and please put them into the Q&A, and they will be moderated from there, as Brooke mentioned. So without further ado, I would like to express my honor in having Dr. Christopher Tremowan, the the Secretary General of APRU, to provide a welcome. Dr. Tremowan, thank you.
Thank you so much for the introduction, Professor Negan. It's great to be here and to welcome the participants and to congratulate all of you for such a wonderful seminar that we're going to have. I first want to thank, of course, the Office of Global Engagement and the School of Public Health at the University of Sydney for hosting this. It's wonderful to have this, and thank you very much. As has been mentioned by Joel, this is the final in this webinar in a series of 4, which kicked off last September. First one explored the experiences and lessons learnt during the COVID-19 prevention and control across 4 countries: China, Australia, the US, and Singapore. The second focused on insights and case studies of academic governmental partnership. And the third discussed the issues of vaccine development and the inequality of distribution issues we're facing right now. And you can find the recordings of these on APRU's YouTube channel. But today, as has been said, the pandemic has highlighted the relationship between communicable diseases and non-communicable diseases. And in this global emergency, public health measures to deal with COVID-19 have been given priority, of course, over other interventions to prevent and control NCD risk factors such as tobacco, alcohol, sugar, and also promotional campaigns for physical activity and healthy diets. So this webinar will look at the impact of COVID-19 on common NCDs, and it will aim to compare experiences and discuss different approaches to prevention and control during this time of COVID. So I thank and look forward to the leading experts who are speakers today in this webinar: Professor Melody Ding from the University of Sydney, Professor Wei Hui Lin from the National University of Singapore, Professor Jue Liu from Peking University, and Professor Kuo from UCLA. Now, just for those of you who are new to APRU, let me just say a few words. We have actively supported the development of the APRU Global Health Crisis Program in direct response to the impact of this COVID-19. And as you can see from our members positioned around the Pacific Ring of Fire, we have every interest in doing so, because we not only have leading research institutions, we have many different responses to the public health crisis. And the connection between our research and educational depth and, of course, what governments and authorities do has been a big challenge and an opportunity both. Now, if you just see the next slide, we have a list of our members. So those of you who want to know the reach of this network, you can see it there, and it's an extraordinary reach across the globe. And of course, we can have a major impact globally if we work together on these issues. In the next slide, you'll see that we have taken some considerable focus on COVID-19 crisis as a result of the enormous resources our members have. And the Global Health Crisis Management Program was initiated by Peking University School of Public Health and joined by UCLA, the National University of Singapore, and of course, our host, the University of Sydney. These are the four key members who have been building on their experiences of how the pandemic has impacted their four cities and countries in different ways. And this work of this program offers us all the opportunity to examine and reflect on each university's responses to the pandemic and lessons learned for future public health crisis preparedness and management, especially in the higher education sector, but in society at large. So you can explore all these resources on that website at the bottom of the slide, apruplus.org. And just to give you a little bit of an overview, we have many activities across the region and thousands of people meeting, but these are the core areas we focus on: shaping higher education in Asia and the Asia Pacific, creating global student leaders, and third, solving Asia Pacific challenges. And the fourth slide there, which doesn't have any words on it, is our interaction with international public policy. Just to go into number 3 a little on the next slide, these are the program clusters that we have: Asia Pacific Women in Leadership, Digital Economy, Global Health, Multi-Hazards, the Pacific Ocean, Population Aging, Sustainable Cities and Landscapes, and Sustainable Waste Management. These are some of the areas where we bring the research capabilities of our members to bear. And finally, let me thank you again to the organisers of this webinar from University of Sydney, particularly you, Brooke Cahoon-Leslie, and Victoria Romaniuk, and the Office of Global Engagement, and Professor Mu Li and Professor Ying Zhang from the School of Public Health for developing and bringing this webinar together. I'm a political scientist, so I can't really claim any expertise in this area, except to say that we all note the politics of pandemics and of NCDs, and this is something where the medical community meets public policy. So I have a great interest in it, and I wish you all well for a very productive webinar. Thank you so much.
Great, thank you very much, Dr. Tremwan. It's a wonderful introduction to APRU. Yes, we're honored to be a member and a participant in these sessions. Without further ado, let's get into the content of our session, which I'm sure our participants are excited to see. Our first speaker today is Assistant Professor Hui Huan Lin from the School of Public Health and Department of Pharmacy at the National University of Singapore. Over to you. Thank you very much.
Thank you. Thank you so much for the kind introduction, and thank you for having me here. So today I'm going to present a framework to evaluate the impact of infectious disease outbreak response measures on the delivery of routine health services, which in a way largely refers to chronic diseases. So there is a large team behind this project, and we have colleagues from the National University of Singapore, National University Hospital, National University Polyclinics. So this is our primary care, and this project is sponsored by a special National University Health Systems COVID-19 Seed Grant Corps. So in this, we have cardiologists, surgeons, oncologists, infectious disease clinicians, and they really come together to think about what is the impact of COVID-19 on chronic disease management. So the background, in Singapore, we had our first confirmed case of COVID on 23rd January 2020. As mentioned, it's about a year ago, slightly more than a year ago. And we were in the typical Singaporean way, kiasu, meaning that we really want to be very safe and be prepared and escalate when necessary. So it was not clear when we were really in DORSCON yellow, but barely 15 days after the first confirmed case, we went into DORSCON orange. So this is our disease outbreak response system, where orange means that the disease is severe and spreads easily, moderate disruption, etc. So all this happened within 15 days. And at the back end, when we talk to clinicians, we realized that they have started moving things around, canceling clinics, etc. And in preparation to free up more space for isolation wards, etc. And that's when we recognized that actually this is going to have an impact on chronic disease patients. And so we tried to find out from the World Health Organization, we looked around and we realized that there wasn't really any framework for us to evaluate what happens to non-communicable diseases during the time of an epidemic, or in our context, a pandemic. And that prompted us to actually work on this particular project. And I must say that this was the thinking we had in the early phase of the pandemic when we know almost nothing about COVID. So at that point, what we did was we had two parallel efforts. One is a rapid lit review by the NUS team, followed by a stakeholders interview. So the information from the lit review fit into the stakeholders interviews. And together, the goal is to adapt the donor-median outcomes model as a framework for evaluating the unintended consequences of COVID on the health system. So we chose the donor-median outcomes model because it is probably the most well-known framework for thinking about structure, processes, and its impact on outcomes. So for the rapid lit review, the goal was to examine any indirect effects of the past disease outbreaks to extract common themes that can fit into the framework. So we limited the lit review to studies that assessed or describes the impact of epidemics, pandemics, or disease outbreak on other health services, not on the infectious disease itself. And studies that evaluated the impact on patient outcomes, mental health, medical education, etc. were excluded. We included early studies on the COVID-19 pandemic, which were published before May 2020. And the search was done only on one database because of the rapid nature of the work. And we were trying to, it's a race against time of sorts. Yeah. And then the recurring themes from these studies and the evaluation parameters or the indicators of outcomes or impact were the ones that we extracted from the lit review. And as mentioned in parallel, we held stakeholder interviews. And basically, it's an open-ended interview where we ask them a couple of leading questions and we prompt them along the way. So some of the leading questions include, what aspects of your work have changed as a result of COVID-19? So this is where we're trying to identify the structural and process changes. And then we want to also prompt them to think about what are the intermediate impact on health services and patients? And what are some of the likely longer-term impacts on patient outcomes? So the collated responses were then used to identify the indicators that we would use for each of the three components of the donor-median outcomes model, which I will go through now. So this is the donor-median model for quality of care. And basically, it involves three components: structure, process, and outcomes. So the donor-median outcomes model has been adapted for a variety of purposes, and we're adapting it specifically for evaluating the unintended consequences of a pandemic. So what that means is that we need to figure out what are the physical and organizational characteristics in healthcare that has changed as a result or in response to COVID. And we also look at the processes, and by processes, we are focused on the care delivery processes, and that includes how laboratory ordering services, for instance, or medication delivery services have been modified as a result of COVID-19. And eventually, the goal is to measure the outcomes, right? So what is the impact of all of these changes on patients' health status. Or if we are looking at population health, then what's the impact on population health? So in the rapid lit review, we looked through 317 records that were written by our keyword searchers, and we excluded 244 of them as not relevant to our intended purposes, and reviewed 73 of them. Among these 73, there were 64 COVID-related studies and 9 that looked at past outbreaks, and past outbreaks include H1N1 and also SARS. So based on the rapid lit review, we identified the common themes and parameters in studies that evaluated the indirect impact of disease outbreaks. And the list is here. So there is decreased utilization of healthcare services, a delay in pre-hospital care due to infection control measures that were put in place, a decrease in the delivery of non-urgent care, a delay or postponement of elective procedures, organizational changes, so these are the structural changes, emergence of new clinical guidelines, as well as disruption to research and education activities. And I would say that we have seen all of this in COVID as well. So this does suggest that the framework that we're going to develop would be generalizable to future epidemics or pandemics. So as an example, in terms of a decrease in the delivery of non-urgent care, examples locally include that the routine specialist outpatient clinics visits are actually cancelled, and converted to telemedicine. So there was a shift to telemedicine. We are not quite sure whether there was a lot of shift to primary care. We're collecting data to find out, but it will be very interesting to study whether there was a greater shift to primary care. So you might have heard stories from chief medical informatics officers saying that in the past they tried for so hard to get people to adopt telemedicine, but when COVID came along, everybody just instantaneously pivoted. And likewise, we had a lot of struggle trying to get people to seek care in primary care instead of hospital. So it'll be really interesting to see whether people have pivoted to primary care as a result of COVID. And then in the parallel interview that we conducted, so these are the clinicians we involved, and we captured a list of discipline-specific indicators. I'll show you examples of them later on. And one of the most important observation that we drew from the conversations was that we need to think of the impact of the pandemic in different phases, or because the disease actually developed in terms of waves. And in Singapore, we are very lucky. We had only one wave so far, but around the world, there are 2 or even 3 waves of the pandemic. And therefore, it suggests to us that the donor-mediated outcomes model need to be further adapted, and we'll show you what we mean later. So here is a list of indicators, and we developed this for a couple of conditions. What I want to show you here are 3 examples, and the reason for showing these 3 examples is to create the awareness that the indicators are different. So you don't have one common set of indicators across the different medical conditions of interest. So as an example for AMI or acute myocardial infarct and heart failure management, the typical outcomes of interest would be the door to balloon time and mean length of stay in hospital mortality, in terms of outcomes, readmission frequency, as well as readmission mortality and complication rates. Whereas if you were to go to post-stroke management, right, then the outcomes or the processes that are affected, include outpatient visits being cancelled and then converted to telemedicine, home deliveries of medicine because it's no longer convenient for patients to seek care within the hospital. Rehabilitation, right? So we used to have in-hospital rehabilitation, but these have to be pushed out to the community now. And the uptake of community rehab, we're hoping that there will be an increase, but this remains to be seen. And then hospital mortality, this is probably one of those indicators that's common across the other conditions. But otherwise, you will see that what we have here is very different from what we have on the AMI slide. And the third example that I'm giving you is that for cancer management, again, the processes that are affected are pretty different. So for cancer management, we're interested in the number of active treatments, number of inpatient and outpatient visits. Maybe this is consistent with post-stroke management as well as AMI. In terms of outcome, will be the overall survival and not just the hospital mortality. So this is our adapted framework. The donor median outcomes model is this, right? So we have the structural changes, process changes, and then the impact on outcome. So we haven't changed these components. What we have done is to be more specific about these components. And this is where our indicators come in, right? So the indicators that I showed you earlier, they will fall into these categories, whether they are structural changes or process changes, and those outcomes that we should be measuring to study the impact. In terms of the different phases or the different waves, we've, from our conversation with the clinicians, we realized that the process changes are actually in tandem with the disease severity or the severity of the pandemic. And therefore, different things are being changed or being done during different phases. In the first wave of the infection, when things are moving relatively slowly initially, we have time to do the structural changes, and we have time to maybe make infrastructural changes as well. So, but as the epidemic ramps up, right, then we're moving very rapidly. And by then, all these changes will have settled down. So this is where we call it a phase where the containment measures are being sustained. And then eventually, we definitely hope that we can scale down, de-escalate into the post-outbreak. But this is also where we need to study whether some of these changes have been reversed. And if they have been reversed, what are the impact on the outcome versus if they had stayed, right? So those are some important inputs we got from our clinicians. And then, so basically, this is what I have just shared about the previous slide. So coming to the discussion, we think and we hope that this framework will provide a guidance for healthcare providers, researchers, health service planners, and governments to objectively evaluate the impact of not just COVID-19, but also any future infectious disease outbreak. And we believe that the model can be applied to different contexts, regardless of the scope, scale, and time horizon, and whether it's for short, medium, or long term. We would strongly encourage the involvement of clinical stakeholders. One of the things that we haven't quite done is to involve the administrators, and that's probably something we will consider moving forward. So one important thing that hit us was that there were many assumptions that we made, and of course, not all of them are correct. One particular example is that we actually assume that the number of patients undergoing active cancer treatment will be affected by COVID. However, in the health system that we spoke to, we were told that there is a recognition of prioritization of cancer patients because of their needs, and therefore, majority of the cancer patients were actually able to receive the care they need unless they choose not to come to the hospital because they are fearful of getting infection. So we have also developed the indicators based on the inputs of a limited set of stakeholders, and we believe that it is important to engage the administrators, the non-clinicians. Besides that, because we have submitted this work for peer review, and one of the feedback we got is that we should really think about getting global input, and therefore we will be submitting a grants proposal to set up an international Delphi panel such that we can get the inputs of a larger community. And I look forward to engaging the APRU community on this project. So we work very closely with our region, meaning the Southeast Asia region, and therefore we are aware that there is limited feasibility for collecting the indicators that we have listed. As you can see, it's pretty exhaustive. And therefore, we will be working with our regional colleagues to develop a shorter version that focuses on the essential list. So I just want to mention that this is different from the WHO list of essential services that needs to be retained during a pandemic. What we are referring to here is an essential list of indicators to capture in order to evaluate the impact of a pandemic on the health system. So in terms of future plan, we have data, patient-level data from a regional health system within Singapore, and this comprises of data from hospital and primary care. And the data will include medicines, lab tests, surgical procedures, diagnostic procedures, etc. The data are from February 2018 to August 2021. So we will make use of this data to test out our framework. We will attempt to construct the list of indicators based on data available in our electronic medical records. And doing this, we want to identify data gaps so that we can make recommendations on how those data can be collected in an efficient manner. And we will be comparing the pre and post-COVID to evaluate the impact of COVID. This is not an ideal study design, but at the moment, there is no way to have a control parallel arm. Everybody is exposed to COVID. But we will be applying econometric methods to try to manage confounders. And with that, I thank you for your attention, and I look forward to your questions and feedback during the Q&A session. Thank you very much.
Great, thank you very much, Assistant Professor Lin. Very interesting and challenging presentation about the realities of service delivery in this context. Without further ado, I would like to move on to our next speaker, Professor Tony Kuo, Adjunct Professor from the Department of Epidemiology at the UCLA Fielding School of Public Health. Over to you, Professor.
Sure. Brooke, can you put up my slides there?
Yes, they are coming up now. Great.
Great. So it may be in a slide format, but
it's coming.
Okay. Thank you. It's a real pleasure to be here, and I think it's actually quite appropriate to follow Dr. Lin's presentation, because in the United States, we certainly are looking for a good framework on how to handle non-communicable disease prevention and control during this era of COVID-19 and probably moving forward.
Can I just check that you've got which one you're actually being able to see? Because I've got 3 monitors up here now. Are you seeing the one that's got my mouse going over it at the moment, or are you actually seeing the full version?
We're seeing your mouse going over.
Aha. All right. One moment while I just change that while you're speaking.
Okay, great. So I wanted to move to the next slide.
Sorry, one moment.
Go for it.
Okay.
Okay, thank you.
Yeah, thanks. So maybe where to start with in terms of so what I thought I talk about a little bit is what we're doing in the United States from more of a public health practice perspective, and where there may be opportunity to apply research, where some of the NCD concerns and patterns that we're actually seeing, and then probably talk a little bit about some of our local and probably national efforts in terms of NCD control and prevention, but from a perspective of what was happening before COVID, and then what's actually probably likely to happen post-COVID, and sort of project what might be ahead. And so I'll start out with this slide, which really basically, this is a statistical process chart where we're looking at COVID-19 deaths in the United States. And as you can see, for the last 12 months, we just recently hit a whole year. You could kind of see 2 peaks, and certainly a bit of a roller coaster ride in the United States, and likely reflects a lot of variability in which policies and response efforts was done across the 50 states. Next slide. And if you take United States and you actually compare it to Australia and in China and Singapore, you could kind of see how that compares. And again, part of it is in the United States, probably the variation in the way the response has gone. Next slide. And locally, within the context of UCLA, this is also to kind of just show you what's happening in California. Obviously, we just recently went through the winter surge. This is COVID-19 death. Next slide. And in LA County, where University of California, Los Angeles, UCLA is located, you see sort of a similar things in both reported deaths and also reported cases. Next slide. And recently, one of our projects is trying to figure out what actually historically in 1 year what actually has happened, and this is sort of an annotated statistical process chart, and we're charting this in a way because down the line we're going to start looking at NCDs and see how that actually compares. And also just to give you an example of the role of response, I actually play a dual role. One of them is actually in the field with our public health department trying to address the pandemic. Next slide. And in terms of non-communicable diseases or chronic diseases, it's just to show you that the leading causes of death. This is pre-COVID in 2019. As you can see, heart disease, cancer, some of the
Sorry, it just went away.
Yeah, right, there you go. Some of the like Alzheimer's disease, dementia, diabetes, these are actually came into play during this past year during COVID pandemic, and these are leading causes of death, and I suspect will continue to be leading causes of death in the United States as we head into 2021. Next slide. And indeed, when the Center for Disease Control and Prevention, our CDC, actually looked at some of the cases of COVID, they found that hospitalizations were 6 times higher and deaths 12 times higher for COVID-19 patients with reported comorbidities. Next slide. And when you look at some of the data, there was a study that was actually done by Quest Diagnostics, one of our United States largest laboratory, and they actually found that during COVID-19, there was really significant reduced visits to healthcare providers, and they're just delays. So like 17% literally with worsening symptoms, 18% delayed diagnosis of a condition, 23% delayed treatment, 31% greater stress about a health condition, and literally more than 1/3 actually have no plans to resume visits until better pandemic control or vaccine distribution is done. But the latter two, we don't really have a clear sort of endpoint. Next slide. And then if you look around some of the other data within the United States, there are other considerations where they know that early on when they looked at 2019 through 2020, cancer diagnosis or identified cancer was a problem. It actually declined, which reflects probably, again, delay in care. You look at the first 8 weeks, March through April, some of the testing for diabetes and hemoglobin A1C volume actually reduced. 2/3 of hospitalization of US adults from November 2020 were actually attributed to the 4 cardiometabolic conditions: obesity, hypertension, diabetes, and heart failure. The first 3, of course, is in many ways what the NCD prevention and control concerns we're going to have to face as we get out of the pandemic. And then, of course, one area we also had worked very hard on pre-COVID, which we're going to have to work on post-COVID, is the issue of smoking, e-cigarette pandemic, which during COVID is actually associated with a risk as a risk factor for hospital admission. Next slide. And again, at least in the United States, this one is a snapshot of LA County, but in the United States, we do have racial disparities. Heart disease and stroke very prominent in our Black communities. Next slide. And hypertension, this was a study that we actually did with the CDC, and what it shows is that if you look at across these two time span, even though there's better awareness and better treatment for hypertension, the fact of the matter is over 50% or nearly 50% of people in the United States still do not have their blood pressure controlled. Next slide. And then this is the other trend that I think it's not being talked about quite a bit, at least in the United States, and that's the Alzheimer's disease and related dementia. I know during COVID, some of our most largest volume of mortality actually was experienced in the skilled nursing facility and nursing homes, and many of those are actually dementia, people with dementia. Next slide. And what does this all mean? What does this all mean, at least for us in the United States? And this is just a snapshot of LA County. If you look at it by city and some of the unincorporated communities, you literally could see a different pattern. If you live in more affluent area, you actually is expected to live close to 90 years of age. But if you live in poverty or in lower or more impoverished area, your life expectancy is closer to 75. So this disparities is one of the issues we're dealing with, especially with respect to NCDs. Next slide. And then we often forget that before we actually got into the COVID pandemic, we were actually working on vaping epidemic, which was quite, especially among youth, was quite pronounced, at least in the United States and certainly locally near UCLA. Next slide. And as around the world, but this is probably more so in the United States, we had the vaping associated pulmonary injury that resulted in quite a lot of death, especially among young people and hospitalization. Next slide. And so I want to say a little bit about what we have been doing pre-COVID and what many of these efforts will be just as important, if not more important, post-COVID, and even as we get out of the pandemic. One is, of course, in 2016, we had raised tobacco product taxes, and part of it is, smoking is such an important behavior to change, and locally and in the state of California and also nationally, there's always been tobacco control and prevention program with some emphasis on reducing youth access, reducing exposure to secondhand smoke, trying to get people who have been smoking to actually quit smoking, and certainly a very robust media and public education campaigns. Next slide. And it's just to show you some of the efforts we were doing pre-COVID, and we recognize that we're probably going to have to amp this up post-COVID. And in fact, we're starting to do this, especially as our schools are about to reopen. Next slide. And the reason I want to show this is that we did do a study, and we basically recognized and was able to demonstrate that policy, especially around behavior like tobacco control, does work. Can you show next slide? And in this study, they basically looked at a state exposure ban for a car, and it's just to show you that after the policy or law was put in place, there is a drop in terms of being exposed to secondhand smoke within the car. Next slide. And overall, in terms of how we have looked at how to handle NCD, is that we know that NCD can be tackled in multiple ways. So you look at obesity and chronic disease, we could certainly work on policy system change and also even individual intervention, but you could focus it on public transportation, you could focus it on better built environment and certainly better food environment, so you have access to opportunities for healthy food as well as physical activity. Recently, we also recognize, at least in the United States, that there's a lot of area and neighborhoods where we probably do need to address crime and violence, and that probably would also result in better opportunities to do the type of behaviors that help you with NCDs. And then social cohesion and social isolation and mental health, both of which actually came out to be quite an important factor during this COVID-19 pandemic. Next slide. And just to give you an idea, pre-COVID, we actually had a healthy hospital food initiative going on where we worked with multiple hospitals to try to improve their food and beverage options, including even sodium limits for their food and vending machine items. Next slide. In lower income neighborhood, we actually try to help develop neighborhood market network that actually sells and offer healthier food. We even started, at least the local public health department started a purchasing cooperative and distribution effort that actually are able to deliver fresh produce to smaller businesses, but in very low income areas. Next slide. And of course, we've been trying to promote community physical activity through school sites through the share use agreement that opens up open space for physical activity to the community, but using school spaces and facilities. Next slide.
Just a reminder for time.
Okay, thank you. And then community plans. Go ahead, next slide. And of course, media campaign, we certainly have done a number of them. Next slide. And this one just to show diabetes prevention program resources. Next slide. One of the projects we're doing now is we're trying to address food insecurity, and we have this thing called Produce Prescription Project. And this one is we're trying to screen for food insecurity in clinic and actually get diabetic patients into a program where they could actually buy, using a voucher program, buy daily food, better, fresher produce. And using that to get a healthier diet and to help control diabetes. Next slide. Let's go on, next slide. We certainly, during COVID, what we recognize is that we could actually do a lot of these wellness activities through things at Wellness Center, and also convert many of the previously in-person work to actually virtual contact. Next slide. And it's just to show you what they actually at this Wellness Center, they use Wellness Navigator, and they converted many of these programs to actually virtual visits rather than in-person visits. Next slide. And again, just to show you what actually changed in literally a matter of months because of the COVID-19. Next slides. And certainly there's demand for it. The phone calls and checks actually went up throughout the year. Next slide. And finally, I wanted to mention, certainly at UCLA, we contributed to a lot of these efforts through research with focus not as much on traditional basic or bench research, but starting to be more applied research, looking at implementation or using implementation improvement science to actually study some of these processes and help agencies improve their program. Next slide. And again, one of the areas that I am particularly interested in is also trying to improve medical education, including trying to recruit more underrepresented population into medicine. Next slide. And I'm going to end with this. In many ways, for our effort in terms of NCDs, we realize that mortality and morbidity is often not just about access to clinical care or health services, or just changing health behaviors. In recent time, we definitely is starting to work on things like the built environment. We realize social and economic factors play a very important role, especially in the United States. And I think I'll end my presentation here. Again, thank you for the opportunity to talk about what's going on in the United States.
Right, thank you very much, Professor Kuo. It's an amazing sweep of the challenges facing population health and NCDs in Los Angeles in particular, and a very powerful call to action on the social determinants of Health. We'll move on now to Associate Professor Melody Ding, who's an Associate Professor in the Prevention Research Collaboration at the School of Public Health here at the University of Sydney, and who's a leading researcher in physical activity. Over to you, Melody. Thank you.
Hello, everyone. Thank you so much for the invitation. And for someone like myself who lived in China, in California, and in Sydney, I feel really at home at the Pacific Rim Network. So today, I feel really honored to be here, and especially to follow on two very interesting big picture presentations on the implications of COVID on NCD. And for my presentation, I'm just going to take a very tiny slice of that bigger NCD conversation to focus on physical activity as a case study. And again, here I want to acknowledge the traditional owner of the land and the elders from the past, present, and emerging. We all know that physical activity is important, and the WHO just released a new physical activity and centered behavior guideline at the end of last year. And we know that physical inactivity is responsible for a broad range of non-communicable diseases. And one thing that didn't get to be written into the guideline, but we're getting to know more and more, is that physical activity plays an important role in immune function as well. For example, there has been research showing that those who have been habitually active are less likely to end up having severe symptoms when they're infected with SARS-CoV-2. So it's a very important issue we address. And emerging from the recent WHO physical activity guideline, there's this important message, and stronger than ever, that every step counts, every bit of physical activity counts. We used to be obsessed with a magic number of 150 minutes. Now we really start to understand, and the data are showing that, especially when we're moving people from doing nothing to doing something, that's when we're seeing the biggest gain. So every step matters. So knowing that every step matters, and how is this change that we all experienced in the last year going to affect us? Because we used to live like this, free range, and we used to, take public transport to work and hug our colleagues. We all miss that, I know. And then we're now gradually adapting to a completely different and more confined lifestyle, especially in the early stages following the first wave of COVID-19. So what does the evidence say? Intuitively, we will think immediately that, well, after COVID-19, after the lockdown and other restrictions, of course, our physical activity is going to decrease. But then there's some evidence showing that in particular settings, it might increase. And it might decrease in some other studies. And there has been around 100 studies by now. And some studies find that they stay roughly the same, and other ones found that the evidence is mixed. Some people increase and others decrease. So why are we seeing such a diverse, heterogeneous evidence here? So to give you the context here, there's a lot of factors that could affect what the results are. For example, the specific policy settings and the restrictions at the environmental level that differ. So the evidence coming from China might not be generalizable to people living in Belgium, for example, and the same with different states in the United States. So certain states have more stricter restrictions and others have loose restrictions, so that will have different impacts on people's physical activity level. Important distinction here is physical activity versus exercise. For example, at the early stage, about 2 months into the first wave globally, Garmin has released some very interesting initial data about how people start to behave differently. Of course, this is on Garmin users' collective data only. And the interesting pattern we're seeing is that overall physical activity volume seems to be decreasing because we're missing all these incidental activities, such as walking to a bus stop and walking upstairs at work. But the exercise sessions that was logged by users who are wearing Garmin devices actually increased. So how do we really consolidate these findings that seem so different? And the context of physical activity might matter as well. Studies from Belgium showed that those who used to do team sports and social physical activities tend to experience the most decrease after lockdown, as we could imagine. And those who used to do solo activities are more likely to keep up their activity levels. And there's a huge issue here as well, that is study design, because when we think about the initial stage, almost exactly a year ago, when countries around the world started to lock down, that was with a few days or sometimes not even a day of notice, and all of a sudden everything's shut, our lifestyles changed. And if at that point you wanted to collect data prospectively and go through the ethics office and say, I want to measure people's step counts now, and then I want to measure it 2 months later, it's just impossible. So because of that, the majority of the data so far are retrospective, by asking leading questions such as, do you think COVID-19 has negatively or positively affected your physical activity levels? And we know that there are biases associated with these type of questions. And the sample characteristics are different, whether it's a volunteer sample, relatively health conscious, or it's a population sample. And finally, physical activity could be measured by questionnaires and different type of questionnaires, or by devices that are objective and less subject to reporting bias. So this is one of the really interesting studies that emerged during this period. Out of all these evidence, I picked this one because this is based on activity tracker and is looking at different countries and really seeing how almost all countries had some sort of drop around February, March last year. This is step count data, but each country has different trajectories. And this again has a lot to do with the second, third waves and the policies implemented in these different countries. So here, I'm very excited to share a few case studies that I did myself as part of the contribution to understanding the role COVID-19 played on physical activity. And this is the first time I'm showing these results to anyone, so I'm really excited about that. And as you can tell here, based on the location, it's very much got a Pacific Rim flavor. So the first study I did earlier was how people's online search behavior changed as a result of COVID-19. Because we know that at least in the 3 English-speaking countries that I got the data from, Google was the dominant search engines. And so I got into ask Dr. Google, how much had been people's searching topics related to exercise. And what we saw is this really interesting surge that we experienced pretty much around mid-March last year. And in all 3 countries, the initial lockdown happened around March 23rd. And what we saw is this huge jump in search volumes related to exercise on Google. And the results were provided by Google Trend. And just to kind of contextualize it, Google Trend has been tracking user search data since January 1st, 2004. And for the last 17 years, this jump is unprecedented, and we've never seen that in Google history, and it's about 10 to 20 times more than average. So unfortunately, we wouldn't know who we're searching, and we can have some ideas in terms of what they're searching for. So the most commonly searched topic is home-based exercise, but we didn't know if those who searched end up doing more exercise. But what we saw is this interesting surge community engagement in terms of information seeking, in terms of exercise. So this interesting kind of proof of concept work was picked up by media, and of course they're interested in making it more sexy than it sounds. So New York Times, for example, quoted a study and said that, oh, people are moving exercise online. And I think it's fair enough to say that it's possible, but we have to acknowledge the limitation, as I mentioned earlier. It could be those who have been habitually active that are particularly interested in now changing their exercise routine from being at the gym to being at home. So it could be that at the population level, we actually don't see changes. But I think this does provide some interesting evidence and possibly positive news that people are really engaging in physical activity, at least in an online information seeking format. And I wanted to show you the second study. So the second study overcame some of the limitations with the first study, because this is actually based on behavior. This is not based on information seeking. And just a very interesting background story about how the second story came about. It was I have been collaborating with Fudan University School of Public Health long term, and we have been running an physical activity intervention studies, and we finished the intervention phase. But initially, the plan is to follow up the participants for a year, and we've got the ethics approval to continue to collect step counts through WeChat for another year. And before COVID-19 hit China, we already finished the intervention phase. So it's just all seems to be perfectly timed now. But at the beginning, we were sort of freaking out about COVID-19 kind of ruining our intervention effect, but it turned out to be a great opportunity for us to have one of the first prospectively collected data on COVID-19's effects on physical activity. And what we saw is that, around January 24th, that's the start of Chinese New Year last year, we saw this sharp drop, and using causal influence methods, we can tell that that's clearly caused by the lockdown in step counts. And then the drop is about 4,000 steps a day, and it's a huge amount. And it stays very low for about 2 weeks, and they gradually start to recover. And at the end of the lockdown, that was around 2 months later, and we saw that the step counts basically moved almost back to baseline. It was still about 500 steps short. So people did recover, but we're not sure if they recovered completely to baseline. And another interesting finding was that we're looking at how people responded to COVID-19 lockdown differently. And we look at the predictors of physical activity during COVID-19 lockdown and after the lockdown. And some of the characteristics here are the same. So those who are older and those who are married, they tend to recover their step counts slower. And the interesting one we saw here is that those who are university educated seems to recover their steps slower during the lockdown, but faster after the lockdown. So we thought the explanation could be that university educated participants were more likely to be knowledge workers. They were more likely to be working from home during the lockdown. And they're also more likely to have the financial resources to use alternative transportation if they had to travel during the lockdown. So for example, based on Chinese National Travel Survey, before COVID-19, 5.8% of the participants travel by taxi and cars. And during the lockdown, that 2 months you saw is 45%. So we thought that that could explain the reason why we saw these two groups behave differently before and after the lockdown. And as we can imagine, those who are less active before COVID, they're also more likely to be inactive during COVID. And those who have high at-risk adiposity based on body composition were also more at risk because they recovered their step counts slower. And for the third study, we're moving on to the other side of the Pacific Ocean. So this is data analysis based on the Understanding America panel study. And this population representative panel for around 5,000 people repeated over almost 300 days and about 20 surveys. And the question was quite broad here, and it's asking only about leisure time physical activity, which is what we often refer to as exercise. We're asking people how many days they do exercise during the week. As we see here, it's roughly a flat line, but with some reduction. The data collection unfortunately started after COVID-19, so we can't compare with pre-COVID. But at that time, during the US, there has been second or sometimes third wave, so there has been fluctuations. But physical activity remains mostly stable with some trend for decline, which could just be seasonal because winter. And we're also interested in those who are more at risk during COVID-19. And what we're seeing is that it's quite similar, consistent message we're getting in relation to what we found in China. So those who are more socioeconomically disadvantaged were less likely to be active. And we also look at the environment, which is how strict the containment policies are at the state level. And what we found was a inverse association. So stricter policies, less physical activity. So that's my 3 case studies I quickly flew through. And this is my last slide. I just want to kind of share with you what I think we have learned from this. So we don't quite know precisely in every location how physical activity has changed at a population level, but we do have evidence that it's very likely to be a negative impact. And even being physically inactive for a short period of time, that could have altered our metabolic system and change our body composition. So that is still a concern, even if we recover after COVID. And it seems to affect certain populations, subgroups more than others. So there are opportunities ahead because there might be potential increase in awareness and interest. And interruptions provide opportunity for us to rethink about how we build our cities, for example. And in Sydney, we're seeing pop-up bike lanes that and surge in people using bicycle for traveling. And the challenges remain, that is socioeconomic gaps that could be exacerbated and competing priorities with containment policies and increasing private car use that some of you might have experienced anecdotally. Thank you very much for your attention. And I look forward to sharing more of my research with you during Q&A if you have any questions.
Great, thank you so much, Melody, and thank you for sharing that new data with us. It was fascinating to see the different responses and the nuance in the different settings. Our last speaker today is Assistant Professor Zhu Liu from the School of Public Health at Peking University. She's an Assistant Professor of Epidemiology and Biostatistics. Welcome, Professor Liu.
Thank you so much for introduction. And thanks for APRU for inviting me to join in this webinar. It's my great pleasure to be here, and my presentation will focus on the impact of COVID-19 on diabetes in China. I'm Liu Zhi, Assistant Professor in the Department of Epidemiology and Biostatistics, School of Public Health, Peking University. It is well known that diabetes is a metabolic disorder caused by genetic and environmental factors. And this disease has become a critical health concern worldwide, owing to its high prevalence and related disability and mortality. And the prevalence and numbers of adults with diabetes has increased at a greater rate in lower and medium income countries than in high income countries recently. According to the latest estimation of GBD study, which was recently published in The Lancet, diabetes is among the top 10 causes of the disease. In this slide, you can see that it is ranked 8. And the situation in China, China has the largest number of patients with diabetes in the world. The prevalence of diabetes in adults living in China increased from 0.67 in the year 1980 to 12.8% in the year 2017. It is estimated that there are more than 110 million adults with diabetes living in China, accounting for 24% globally of patients with diabetes. According to the 2017 National Survey of Diabetes in China, the prevalence of diabetes and pre-diabetes was 12.8% and 35.2% respectively. Additionally, the healthcare cost associated with diabetes in China is about 110 billion international dollars in the year 2017. That means it is a great burden of diabetes in China. So how to prevent diabetes and control, giving better control of the diabetes, take good care and during the COVID-19 pandemic is a great challenge for China. And this slide shows the overview of 4 national surveys of diabetes in China, which were conducted in 2007, 2010, 2013, and 2017, respectively. And I give the key findings of the 4 national surveys conducted in China. You can see that for the total diabetes, from the prevalence of weighted prevalence of total diabetes has been increased a lot, from the 9.7 in the 2007 survey to currently 12.8, and for the diagnosed diabetes, we can see that it's increased also. But the undiagnosed diabetes, it is decreased from the 8.1 in the 2010 survey to the 6.8 in the 2017 survey. And for the pre-diabetes, we can see that it is actually decreased, because the survey conducted in 2007, it is used the WHO criteria, and the other 3 survey is in ADA's criteria. So the prevalence, maybe the last 3 national survey is more comparable. So we can see that the pre-diabetes is decreased. And for the awareness of diabetes, treatment of diabetes, it is also increased, as well as the control of diabetes. We can see that the treatment of diabetes, the prevalence is almost doubles. So getting back to the global burden of COVID-19, it is well known that yes, COVID-19 is an emergency infectious disease that has spread rapidly around the world. Globally, there has been more than 110 million confirmed cases of COVID-19, including more than 2 million deaths reported to the WHO. And for China, there are 90,000 confirmed cases in China, include more than 4,000 deaths. And there is a bi-directional relationship between COVID-19 and diabetes. On one hand, diabetes is associated with increased risk of severe COVID-19. And on the other hand, new onset diabetes and severe metabolic complications of pre-existing diabetes have been observed in patients with COVID-19. So this poses challenges in clinical management on diabetes, especially during the lockdown periods because of COVID-19. So our research group we aim to systematically evaluate the prevalence of diabetes among the COVID-19 patients in China and its impact on clinical outcomes, including the severe cases of death. We conducted a meta-analysis, research studies published in the PubMed Web of Science in EM-based to identify relevant observational study. And we finally included 23 articles because this study was conducted in last year in April. So the articles we already included 23. Yeah. Our findings show that nearly 1 in 10 COVID-19 patients have diabetes in China, and the pooled prevalence of diabetes was about 10% in COVID-19 patients. In the subgroup analysis, we found that the pooled prevalence of diabetes was higher in studies with patients aged more than 50 years old than in studies with patients aged less than 50 years old, and also higher in severe patients than that in the non-severe patients. And it also higher in the died patients than that in the survivors. And we also found that compared with patients without diabetes, diabetes is associated with a greater risk of severe illness and death in patients with COVID-19. The risk of severe cases was high. The risk ratio was about 2.13, and the risk ratio for death is about 3.16. So diabetes is also shown associated with high risk of severe illness and death in patients with COVID-19 in China, just as findings in other countries. So about the impact of COVID-19 on diabetes in China, scientists most focus on the impact of COVID-19 lockdown on diabetes patients because their lifestyles, the glycemic control and diabetes management facing more challenging during this period. And also, we found that there are more risk of severe metabolic complications of pre-existing diabetes during this period. Also, in some researchers, they found that there are some COVID-19 related new onset diabetes. That means among the COVID-19 patients, some patients without any history of diabetes, but they found a new onset diabetes. But in this period, in this field, it needs more researchers. So give some progress on this field. Some researchers did research to think out the association of blood glucose control and outcomes in patients with COVID-19 and pre-existing type 2 diabetes. They use data from the cohort in Hubei province in China. We all know that the number of confirmed cases is most in Hubei province. So they found that subjects with diabetes, with type 2 diabetes required more medical interventions and have a significantly higher mortality. That is 7.8% versus 2.7%, and HR is about 1.49. And diabetes status increased the risk, the mortality risk of patients with COVID-19. Interestingly, they found that well-controlled blood glucose correlated with improved outcomes in infected patients. The adjusted HR is about 0.14. From this interesting picture, the authors gave an interesting picture to show what the findings. That is, in the well-controlled blood glucose group, the survival rate is about 8.9%. But in the poorly controlled blood glucose, they find the death rate is higher as 11%. So well-controlled blood glucose correlated with improved outcomes in patients infected with COVID-19. So these findings provide clinical evidence correlating more proper blood glucose control with improved outcomes in patients with COVID-19. And some researchers also did to investigate the impact of COVID-19 lockdown on the glycemic control in children with type 1 diabetes. And they used the continuous glucose monitoring data during and after lockdown. They also collect data on the basic information and lifestyle change related information. This slide shows the basic findings. They find that during lockdown, the individuals reduced their physical activity and received long sleep duration and spent more time on diabetes management. So this table shows the specific information. and the glycemic control did not deteriorate in the children with type 1 diabetes around COVID-19 period. So there are also some researchers did a national study to figure out, are there any excess mortality in China during the COVID-19 outbreak. They use data from the national-wide mortality registers, and they use data from the 605 urban districts and rural counties in China's national representative DSP system. And this system records 0.58 million deaths from January to March. And they find that except in Wuhan, no increase in overall mortality was found during the 3 months of COVID-19 outbreak in other parts of China. And the lower death rates from certain non-COVID-19 related disease might be attributed to the associated behavior change during lockdown. Actually, during lockdown, some good health behaviors are maintained, such as taking masks and keeping the social distance, etc. And in this slide, in this finger, you can see that here is Wuhan, and here's Hubei without Wuhan, here's China without Hubei. So except in Wuhan, actually there's no increase in the overall mortality was found in other parts of China for the disease of, for the excess mortality of diabetes. So these findings highlight the need for rapid and coordinated actions during major outbreaks of infectious disease to contain, suppress, and eradicate transmission and minimize the impact on the human health and the social and economic activities.
Just a little
Here,
reminder for time. I'm sorry.
Oh, thank you so much. This table shows the specific numbers of the excess risk of the excess mortality of diabetes. And some studies also conducted to figure out the impact of COVID-19 lockdown on diabetes patients in other countries and found similar findings. Here's the study conducted in India, also find that lifestyle changes and the physical distress are identified as the possible factors responsible for the worse glycemic control. For the future research, currently, we have answered much questions on the impact of COVID-19 on diabetes and the impact of diabetes on COVID-19. But actually, because the COVID-19 it is almost all 1 year, the long-term effect of COVID-19 on diabetes still need to give more research. And on the other hand, COVID-19 related new onset diabetes, there are a lot of questions to be answered, such as the epidemiology, how it develops, and the nature, what is a natural history of the COVID-19 related new onset diabetes. Finally, all these researches will gain clues to regarding the appropriate care for patients with diabetes during and after the COVID-19 pandemic. Thank you so much.
Thank you very much, Professor Liu. And thank you to all 4 of our speakers. There's a lot in there and a lot of different perspectives on COVID-19 and its impact on non-communicable diseases. We only have a few minutes left, so please do put your questions into the Q&A. And what we might do is if people put in lots of questions, we can also direct them to our panelists and they can try and answer those questions either directly to individuals or offline. And of course, if people want to email any of our speakers with specific questions, they are free to do so. So please do put any questions you might have into the Q&A, and we'll try and ask 1 or 2 before our time is up. I guess I just wanted to ask quickly quickly, I know there's been a lot of discussion in this session about the challenges and about how COVID-19 has negatively impacted non-communicable disease control. But maybe as we approach the end, I'd like to twist a little bit, and I think, Melody, you did start on this, but what is the positive, what's the most silver lining, positive aspect of COVID-19 in terms of NCD control that you've seen in your own research or practice? Can you give us something hopeful as we finish the last of these 4 APRU seminars on COVID? Does anyone want to start with a positive? I don't want to put anyone on the spot, but I'm wondering if any of our speakers wants to find a silver lining. Professor Kuo, do you want to start?
Sure. You know, the one positive we have found was how, you know, before pre-COVID, there was the pace to try to do virtual visits and getting our, you know, health insurance to actually pay for virtual visits with patients and increasing access to care that way was kind of a barrier. And it's been, COVID-19 certainly has actually accelerated that process. So I think it's actually for NCD control in the future, it's going to be a good thing.
Great, thank you. That's a wonderful example. Thank you. Professors Ding, Lin, or Lu, any examples?
I'm happy to follow up on what I already started. I think this is a great opportunity for us to rethink about how we travel, how we work, and how we can build in more incidental physical activities through, you know, more pedestrian infrastructures and cycling infrastructure. And I think in Sydney's case, we're really building a lot of cycling infrastructure that the city planned to build for 10 years, and it's all get done in 1 year. So I think it's really a positive sign. And in terms of the way we do fitness as well, I think, you know, we have a lot of virtual classes that studios continue to run that really helps people overcome the geographical and transportation barriers. And finally, I think people start to appreciate outdoor space more. And I think it's really positive to see that. And I hope that really leads to bigger conversation in terms of our equality issue when it comes to access to these public and open spaces as well.
Great, thank you. And I think that reflects as well with Professor Kuo's showing of the different life expectancies in different parts of the city.
I have a question.
Yeah, so we have a question from, so can we ask the question from Dr. Guzman? Is that what you're going to do? Yeah. So Dr. Guzman from the Philippines asks, and Professor Lin, this might be for you because it's kind of about service delivery indicators. Would you have a list of indicators for case management for mental health? Due to service disengagement during COVID-19, we had an increase in relapse of symptoms and suicide. Are there lessons to be learned from the models that you looked at for perhaps looking at mental health in a similar way?
Right, thank you for the question. It's a very good one. Unfortunately, we haven't really looked at mental health indicators yet, but it's work in progress. So there are many surveys going on locally, looking at the impact of COVID on the mental health outcomes. So we hope to provide you with something maybe in a couple of months' time, but we don't have anything for now.
And Dr. Liu, do you comment? I mean, I know diabetes and mental health certainly are not the same, but wondering whether your approach or model or indicators might have resonance for how we might look at mental health in this context.
Thank you. I think actually, given from the evidence of the previous studies, we found that the COVID-19 during the COVID-19 lockdown period, actually, it did have some impact on the physiological status of our diabetes patients. So actually, our research group are still follow up and give more research on this field. Maybe in future, some related papers will be published about this field. And we also focus on the diabetes in the pregnant women. And our research found that for the pregnant women during the COVID-19 pandemic, their physiological status was much worse than the period before, because we have two cohorts of the pregnant women. One is before the COVID-19 period, and the other was during the COVID-19 period. And we make comparison and found that the score of SAS and SDS is much higher than before. So I agree that the mental health of the diabetes patients and other NCD patients needs more attention. Thank you so much.
Great. And we perhaps might add as well, Dr. de Guzman, the links between physical activity and mental health as well. So I think there's kind of lots of those connections that we can talk through. We have 1 minute to go, and another question's just popped up. I'm going to read the question, but I'm not sure if we'll actually have time to reflect on it deeply. Dr. Hui Yang of Monash University here in Australia, any study on COPD and flu could represent non-transmitted and transmitted conditions that might be impacted by the COVID-19 pandemics and quality of life instead of mortality could be the better indicator of outcomes. And disadvantaged groups are more valued to be focused. So looking at quality of life rather than mortality, which I think is an important point to make. So thank you, Dr. Yang. And on that note, as we hit 1:30 exactly here in Sydney, and I appreciate Dr. Ko, it's evening for you, so thank you very much for joining us in evening your time. And thank you to all of our attendees for spending time with us and to the APRU for this 4-seminar series on global health and crisis management. Thanks to all of our speakers and to Brooke and Victoria for organizing. Dr. Tremont, do you want to have a final word of thanks? And then we can close it from there.
Oh, thank you so much. I've found this a fascinating series of presentations, and also I should just add, in terms of in a way, the silver lining, if we can call it that, is that we're now focusing on our common challenges in many areas and not on the things that divide us. And I think that is something that we can take forward.
All right. Thank you very much. Have a wonderful morning, afternoon, and evening, depending on where you are, and all the best, and stay well. Thank you.
Thank you.